All right, so I'll go ahead and introduce you, and then I'll let you take it away. Before we start, I just want everyone to know that this is a very interactive and discussion-based session. It's also one of our most popular and well-received. So really one of the high values of this is really the discussion piece that comes out of it. So just ask everyone to please participate and put your cameras on. Don't be shy to speak up, because you'll really get a lot more out of it if you do that. So it's my pleasure today to welcome you to our 9th annual Global Child Health Lecture Series from UCSF, and to introduce Dr. Robin Goldman, who did Med Peds, so holds an appointment both in internal medicine and pediatrics at UCSF. She works clinically in internal medicine as a hospitalist in the San Francisco Veterans Administration, and also as a pediatric hospital at Washington Hospital previously with Sohill. In addition to her clinical work, she's a director of evaluation for the UCSF HEAL Initiative, which is a global health equity fellowship, and she's going to tell you more about that opportunity as well. And Dr. Goldman herself completed the HEAL Fellowship, working with Partners in Health at a hospital in rural Haiti. She completed her master's in public health at the University of California at Berkeley, and her interests are in social medicine, global health education, and creating systems to empower local providers to care for their communities. With that, Robin, I'll hand it off to you.
Yeah, thanks so much for joining. I'm wondering, just as we're getting started, if people want to just write in the chat. I know a subset of you are in the PEDS Global Health track, and then I think this was open to a wider audience. And so if there's anyone else who just wants to say kind of who they are and what drew them to this talk, that would be helpful for context as I get started. Just as a heads up to people, there's a little exercise that I have you do in the middle that I think is easiest if you actually have something to write with, and like it can be just scrap paper. I mean, you can do it in your head. It's a little more challenging probably on the computer, but so if you at some point can grab something to kind of draw with, that would be great. And then as Teresa said, really I think this presentation builds on the input that you guys can give, and so whether through chat or through voice, really appreciate people participating. And I think with that I will, and thank you. Thanks for people chiming in the chat. I'm going to share my screen. All right. So this talk is really about structural analysis, and I think some of you may have heard of structural analysis before, or I think the other term that's used frequently is structural competency. And I think for me, bringing this into how do I actually use this in my day-to-day or clinically, was a gap I felt between sort of learning things in the classroom and actually practicing. And so that's kind of where the motivation for this talk came from. Just want to start out with recognizing that I am on Ramaytush Ohlone land here in San Francisco, and want to appreciate that was forcibly taken from those people centuries ago, and appreciate the ongoing stewardship of the current people of those tribes to this land, and am truly a guest on this land. And I think some of you may be familiar with land acknowledgements, but I think really we do these acknowledgements in the beginning of talks, but then really thinking about what are we doing in our life to actually honor that. So hopefully can plant that seed for you all as well. And then these are just briefly my objectives. So we're looking at frameworks to explore the forces and factors that affect health outcomes, do a little bit of practice on structural analysis and talk about the uses. And then at the end, I'll do a brief overview of the HEAL initiative. And so wondering if people can put into chat either like what is it that brought you or caused you to be interested in global health or health equity. And so it's just people can, you know, put a phrase or a sentence or so. Okay, so equitable care. Okay, like personal and lived experience around global health issues. And I think I part of the reason I start this talk out this way is actually because what global health is a little and like sort of global health equity is probably a little bit different to everyone. I think as opposed to fields like neonatology or pediatrics, like which are a little more defined, like what global health is pretty broad. And so I think people come to it from a lot of different backgrounds and a lot of different paths, and like what it means or looks like is different to many people. And so I kind of start with this, like global health is more a collection of problems than a discipline, but really ends up focused on equity. And the idea of global health equity, this is adapted from a Paul Farmer definition, but it is a multidisciplinary approach from large scale to local, social to molecular, that really takes a biosocial approach to what are biosocial problems. And I want to ground in this because this is why I think looking at the systems and structures that affect the health of our patients is so important. And it's important for people who of various backgrounds, but particularly people who are clinical facing, to be able to have some of this lens in their work. And then, so since we're talking about equity and a quest for equity, I thought I would start with what inequity is. And this is a definition by Kamara Jones, but it's a system of structuring opportunity and assigning value based on pick your axis of inequity, whether that be country of origin, race, gender identity, and there are a variety of other axes. And what these do is that unfairly disadvantages some individuals and communities, unfairly advantages other individuals and communities. And I think the most important thing is that it actually really negatively affects all of society. So even those people who have advantages are negatively affected by inequity. And then sort of moving, I think for the people who have studied public health, this may look familiar, but I don't think is particularly well taught in medical school, or at least not when I was in medical school. But really thinking, again, this goes back to this definition of the interactions of the individual, which is that inner circle or the intrapersonal, and all of the things around it. So the interpersonal interactions, so your interactions with other people, how those are all affected by the institutions that you're a part of, and whether those be schools or other like religious organizations or other institutions within our society. And then all of these different institutions are affected by the community around, and then communities are affected by policy. And so there is this flow, I think, mostly from outside in, but sometimes back and forth between all of these entities, which end up affecting like the patient in front of us. And then this slide shows, I think I will speak for myself, but like when I decided to go into medicine, you know, part of the reason was I like really believed that delivering that like me getting some sort of healthcare training, and delivering care to individuals would really be able to affect their health status. And I think the more that you live and the more that you've probably been interacting, whether in your personal life or your professional life in the healthcare system, you realize that there's all this other stuff that affects the health of the patients in front of you or the health of the people in your lives. And so this is based on some modeling out of a center at the University of Wisconsin. So approximate, but really showing that like actual health care probably contributes about 20% to someone's health outcomes or health status, and that socioeconomic factors, health behaviors, the environment you're in, again, the systems and structures and policies, racism and other axes of oppression all kind of contribute to the other things that affect the health status of an individual or a community. So actually, maybe I'll pause there. Does anyone have any like thoughts or questions or anything they'd like to share? Because that was sort of a fast, big picture overview of where we are in the system. Okay, I will keep going then. So I'm actually going to start with a case. This is based on some of the things that I saw when I was working in Haiti pretty regularly. So a 2-year-old presents with her mother saying that she's being fussy and has had diarrhea. Wondering if anyone, so you're in rural Haiti as the context, any thoughts about like what you're worried about, what a potential differential diagnosis is?
I think broadly, like, oh, go ahead.
No, I was going to say when I think about diarrhea, I'm concerned for dehydration as an immediate issue in terms of how sick the child is. So I would try and assess that to start out.
Great, yeah.
I was going to say I broadly try to classify or categorize it as infectious versus non-infectious diarrhea. So trying to like parse out which one of those things it may be, and if malnutrition in addition to dehydration is a component.
Yeah, all right. Thank y'all. Yeah, and so that I definitely part of the immediate assessment. This is not the particular child I saw, but similar child. And so what you find out as you talk more with the mother is this diarrhea has actually been going on for quite some time. It's taken her a while to be able to come to clinic. It is you know, a number of times a day, though not like profusely watery. You do initial kind of triage vital signs. They're relatively stable. So she has no fever. Heart rate is sort of within normal limits for age, and a normal blood pressure. So wondering how, like, what other things people might either ask questions about at this point or start to think about.
I think I'd want to know what she's been able to eat and drink, and also asking about any other people in the family or community that they know with similar symptoms.
Yeah, so she says actually she has 3 other kids, none of them, they're all older, none of them are having diarrhea or any other sort of infectious symptoms. They have had a lot of trouble getting access to food recently. Her husband and her as subsistence farmers, and there's been some storms recently that have done a lot of washing out of their crops, so they haven't had as much food to both trade with or eat themselves as usual.
There's some questions in the chat. I'll just read them out loud. So how long has it been going on? Urine output, sick contacts, bloody diarrhea, how frequent? I think you answered some of those.
Yeah, so diarrhea is non-bloody. She's still been peeing a few times a day, and it's been going on for months.
How has she been growing?
Mom's not really sure. She seems like maybe she's growing, she's growing some, but not sure like how to quantify that.
Is the diarrhea greasy or yellow? And what is their water source?
The diarrhea is just kind of loose watery, not particularly greasy, she doesn't think. They get water from just kind of a local river. Or stream. So it sounded like Teresa initially brought up like infectious, non-infectious, which I think people are getting to with some of their questions. I will say that you note on exam with the child that she also has some edema.
Another good question in the chat. What is most concerning to the family? Why did they bring her in?
Just like how fussy she's been is probably, it's just like she never seems to like feel well or happy.
And what do they eat on a daily basis, their diet?
Yeah, they tried to barter for some rice, to have at least a little bit each day. If they're lucky, sometimes they can make a bean sauce, but that's definitely not daily. And then there are some fruits that they like can pick up from around, so sort of irregular access, but sometimes they're able to eat some fruit.
And what is their protein source?
Yeah, not a lot of protein in the diet. Occasionally there's a bean dish in Haiti that's called like sauce pois, which means bean sauce, and it's basically sort of like water, like beans mixed with water. And so if they're able to sell some of their crops or or able to make food to sell on the street and have enough money to buy beans, they will do that. But that's probably not even every week. I guess Crystal, no one else is sick like her. And this has been going on for months. So I guess hard to say like this before. It just seems like it's been this like kind of ongoing process. anyone, I guess at this point, like anyone have any differentials they want to throw out there? What seems like more likely, less likely?
I feel like given the chronicity and the diet, I suspect that malnutrition is probably playing the biggest role in the diarrhea. Something infectious I would expect to be more more acute. And yeah, that's probably my guess.
I agree. Protein, energy, malnutrition. I didn't catch where the edema was. You had mentioned that there's some edema. So if there's any other reason to have like like albumin or something of that sort.
Yeah, that's true. I didn't say it. So yeah, just some like bilateral or like lower extremity edema, feet moving up into the shins. But yeah, I mean, again, so this is like what I was most worried about with this child. I think given all the factors that you guys named. So then want to start thinking, so you have a malnourished child, and obviously the proximate cause is difficulty getting food, right? So she's not getting enough protein, she's not getting enough calories to begin with, it sounds like, and definitely not getting enough protein. And so once you start to think about this, and I will say that, like, I didn't think about this all the first time with this one patient, but as the context of like life in rural Haiti became clearer to me, a lot of things start to come up. And so the mom had brought up some of the difficulty. They're rural subsistence farmers and mostly operate on sort of eating what they grow and bartering for other things. And so you have this whole set of things, and she had talked about the rains washing things out. And basically what has happened in Haiti, so if I say like difficulty getting food, like their crop yield is down because of these climate events, which are probably from climate change as like sort of one set of circumstances. The other thing that happens frequently in Haiti, which it took me a little bit of time to find out from, and this was just from talking with patients, is that because of once you have a bad crop year in Haiti, then people look for like other ways to make money. And so one of the ways to do that is to cut down trees and then convert wood into charcoal and then sell the charcoal on the street as a way to make an income. And so it both decreases like trees and general vegetation in the soil, leading to like sort of poor soil nutrition, which then like, again, decreases the crop yield as you continue to plant. And so that like actually turns into a cycle. In addition to like deforestation that has happened by like larger companies trying to like grow like one particular crop. But in the hills, with these small farms, this is the cycle you see. So this is a whole set of things that has affected this child. And then sort of on a separate axis, so all of this, like, then there's the question of like, well, if you can make money, you could just buy food as opposed to being a farmer. And so like, that's what this idea of cutting trees and selling charcoal is, to go towards that. So that is one way that people try to make up for things. But there are not a lot of job opportunities for most people in rural Haiti. There's not a lot of access to education. And that can be probably broken down into maybe even more than two, but like one thing is around language. Most Haitians speak Haitian Creole, which is sort of the language of that has been developed among the like slaves that were brought over from Haiti initially by colonizers. However, the colonizers and the elite speak French, and those people who had access to education. And so there's a lot of like racism and colonial legacy around language, and school is only in French at this point, though 90% of the country speaks Haitian Creole. So going back to colonialism and racism, all leading to this decreased access to education. And then there's funding for education and funding for public services in general, which is very poor in Haiti because they don't have a lot of money. They don't have a big tax base. And if you keep taking steps back, Haiti was actually like paying off a debt to France. There was a New York Times article about this a couple years ago, but paying off a debt to France for the crops France lost due to Haitian independence. When it was no longer there, like they could no longer make money off the slavery of the people working there from the sugarcane and coffee crops. And France didn't forgive this debt until the 1990s. So the Haitian government was actually paying off this debt to France for like 200 years almost, for like lost sugarcane crops in the 1700s. This was kind of like what was true when I was working there. It's gotten even more complicated in recent years with the political situation and causing a lack of like funds effectively going into the country, whether with the caveat that who knows how helpful like foreign donors are, and there's a lot of stuff going into that. But at this point, it's really hard for money to actually reach people that need it through the government because there isn't a government. So this is just like where a few questions actually, and just like talking to some patient families about like what their life looks like got me, and then a little bit of knowledge of the history of the country sort of, or the place got me to this. And so, oh yes, and sorry, there's even more. Agricultural policies have also affected crop prices in Haiti, including like influx of like cheap rice from other countries into Haiti that have like decreased farmers' ability to sell their own rice that they grow in Haiti. There were some policies around like killing off a bunch of a whole species of pigs that were native there because of a concern of an infectious disease, which really devastated some farmers. And then to get to malnourishment, Plumpy Nut, which probably many of you have heard of, has a patent and they sell it, so it's very expensive. So even getting people treatment has a significant cost barrier because of the patenting system, worldwide patenting system. So this is a lot of stuff. And I will acknowledge that you don't have time to do this in like with every patient you see in clinic. But actually would like to take 5 minutes now, and I'll leave this up on the screen. Would like people to pick either a patient they've seen or a case they've heard about or someone they know or have interacted with, where you have some sort of health outcome kind of at the top, and see if you can start mapping out the steps and the systems and structures or policies that have affected that. And I'll give us maybe like 4 minutes just for whatever brainstorming. It can be as messy as you want with arrows going wherever, for y'all to do on your own. Feel free to turn off your cameras. I'll leave this up here just so people can look at it in case it's helpful. I'm gonna bring people back, and I know that was a pretty short amount of time, and maybe I'll stop sharing right now. And then just wondering, like, if anyone wants to say, like, how did that feel? And any range of thoughts or emotions are totally fine.
And like one thing would lead to another, would lead to another. There's like this rapid cascade of of things, I felt like.
I think what I was reflecting on is how I had maybe like thought about the first layer of all the different determinants around this patient's presentation, but like hadn't taken it 3 or 4 steps deeper. And it was kind of nice to have a moment to dive a little bit deeper on that.
Yeah, and I mean, something that I think typically in our day-to-day, like there's just not that both the time or the like mental bandwidth to do that. Yeah. Anyone else have anything they want to add?
I really like the idea of like the connecting, like actually using the arrows, because I feel like often when I think about a problem, I think about each of the disparate things versus actually seeing how those are tied to connect each other and then also connect to layers further up. So yeah.
Yeah. And I will say when I first did this presentation, like getting the arrows nice enough so that like you can see it on a PowerPoint with like it's actually almost easier to draw it on a piece of paper where your lines could be super messy and you're not necessarily showing anyone. Yeah, Barbara, and totally want to validate that like it can feel overwhelming. And I think like to what Teresa said, like well the one thing, then you like think of the next thing, then you think of the next thing. And I would say like even, you know, like as I'm giving this, I'm like, oh, well, since I've been in Haiti, like the government has like it's become a failed state. And like there's like probably even more layers of messiness that I could add to this now. Or if I were working there now and are affecting like these patients and these communities. And yeah, I think Sarita, part of the point is like not all of these are medical, right? Like there are so many things that affect our patients that feel outside of like what our like day-to-day looks like, especially if you're a direct care provider. I think for the people who are either like public health or in global health master's programs, you will probably do things that are sort of much broader than those of us who are in clinical care, at least at first. And so can kind of feel, I think, yeah, overwhelming, discouraging, outside of a scope. I think I purposely pushed y'all a little bit to do that here. And so I'm going to jump back into this PowerPoint because I want to say that this was not just to make you feel overwhelmed. I just want to ground, and this again is based on some of the work by Kamara Jones. But when we think about inequity, there are different levels of inequity. And so one of them is the institutionalized inequity. And this goes kind of back to the levels of the socio-ecological model, and everyone has a little bit of a different way of talking about it. But she defines that as differential access to goods, services, and opportunities. And that this really operates on a societal and structural level and is the result of policies as well as societal norms and inaction by people in society to change them. And then there's the interpersonal level of inequity. So assumptions that we all make about ability, motives, intents, and these can be, you know, I think unintentional or implicit, as well as intentional, and lead to prejudice and discrimination. And then the sort of innermost level is this internalized level or interpersonal level, where people start to believe, as a result of the 2 prior levels, start to believe things about themselves that aren't true, or their own abilities or intrinsic worth, which then kind of continues to perpetuate that cycle. Oh, I did this. I'm gonna skip that. So to get, I think, to the question of kind of, for those of us who are not policymakers, or this feels like really kind of far from our day to day, there actually is some evidence that even if what you're doing day to day can't actually or doesn't actually affect any of the things that you mapped out with your arrows, talking about them with patients and acknowledging them has a really positive effect on patient relationships. So one, increases provider or like the healthcare worker empathy, and patients report improved relationships with their providers when they're asked about the social determinants that they face, and identify, even if the provider can't do anything about it. And then the other, I think, point I really want you, like the take home point, is that you can't change anything that you don't identify. And so I think I will say for myself that, like, asking about these things felt overwhelming because I felt like I wasn't able to do anything about anything. But there are some things that even if you can't do something about it, maybe someone in your clinic can do something about it, or someone can do something about it. And if you don't bother to ask, you know, in addition to your patient maybe feeling like you feeling unheard, or that maybe the healthcare system doesn't care about these things, without identifying it, you won't be able to change. You won't be able to even advocate for change. I think asking patients about their story and really listening to it firsthand can be really powerful. I think both for identifying some of those factors and challenging implicit biases that get perpetuated throughout the healthcare system, and for making systems changes, and whether that be big or small. And then I think what tends to be many people, particularly people who are interested in health equity, and go into these fields where it's really about trying to serve people who have been marginalized, like, tend to be very humble people. But I think you have to remember that any sort of professional training in the healthcare sphere gives you a level of authority that many of your patients don't have, and that your voice can really amplify your patient's voice and help others make change. And so I'm, oh, and we're going really fast, actually. So I'm gonna end this, I think, hopefully with a story that makes it feel better for the case I have. So I think, so malnourishment is a huge problem in Haiti for all of the factors that I outlined, and I think Zami La Santé, or Partners in Health in Haiti, really did just focus on like, we need to treat malnutrition, and actually at some point someone approached Partners in Health, and it was someone from, like, the agriculture department of a university in the US, asking about working on a sustainable agricultural program with some of the populations that in the Partners in Health catchment area in Haiti. And so this is called, so Partners in Health is translated to Zami La Santé, which means Friends of Health. And this the conversation that was started between like a professor at this university and Partners in Health ended up forming this organization called Zami Agricole, which means Friends in Agriculture. And basically they started both sort of a education program around sustainable agriculture that worked with communities that had high rates of malnutrition and sort of poor crop yield, as well as so that's how it started, of sort of trying to teach like sustainable agricultural practices to both protect the soil and the land and to increase crop yields. And then I think over time, the organization grew and they started sort of microfinancing or micro lending around animals. And so there is a like goat lending program through this organization where like basically they'll like give a family a goat, the goat will have babies, and then the family gives back like baby, you know, 1 or 2 kids, I think are the baby goats, back to the organization as sort of like ways to repay that, which then get lent out to other families. And the goat provides like income or like a revenue source for that family, and sort of that self-perpetuates its own lending program. So they also started that. And then this came much later, but Zami Agricole then actually developed a sort of like professional training program, both around agriculture and then added on some other skilled trades like carpentry, for example, and like focuses on particular like higher yield crops. And so I think this all came out of people who were patient facing, talking about the problems with malnutrition and talking about the problems that they're seeing with their patients having with farming, and catching the attention of someone who actually sort of had the skill set to try to start to help address this. And so I think what felt most powerful about talking to the people in this organization to me is that it wasn't as if the clinical people or the patient facing people had to come up with the like, we need a plan to fundraise to like create this like sustainable agricultural program, but just bringing it up like brought enough attention to some people who did happen to have the skill sets to develop a program. And now, I mean, both the healthcare on the Partners in Health side, as well as Zami Agricole, are like pretty much Haitian run organizations. And so I think there is some fundraising that happens, but this is really about like people locally, like both like treating and talking about and teaching other people locally. And so I found this really inspiring along the way. And then I will add, I don't think I have a slide about this, but the other thing that happened around this issue in partnership with Zami La Santé and Zami Agricole is they started farming peanuts and were able to negotiate with Plumpy Nut, which is fairly expensive. I want to say it's like $20 per unit of whatever unit they have. They got them to give them the recipe for Plumpy Nut with an agreement that they wouldn't sell things and that they would only make the like generic Plumpy Nut equivalent for patients there, which patients could receive for free, and then actually built like a factory with employing Haitians to grow the peanuts and the stuff that went into like the pumpkin nut equivalent, or the generic form, and then employing patients to actually make it, to be able to give that out to in clinics to kids with malnutrition. And so this has like really grown into like multiple separate like larger projects, but really all came from like the patients and community talking to like healthcare facing people about the problems that they were facing, and then these people sort of bringing that to a wider audience. And so I think like my hope that your takeaway from this is that you really need to like name the inequities that are happening that you see around you. Like ask, how are they operating? And then talk about it. And maybe some of the acts to create change are just like about how your clinic is run, or like what forms you give out that people have to do, or even internet access to like whatever app a medical like chart is on, or can be much larger than that. And so yeah, so hoping that this like and things can be little and small, and they don't have to happen for every patient. But I think creating the space for you to ask some of these questions, even if it feels discouraging at the time, is the way to open the door to thinking about like how do we see change? Who might my allies in change be? And like, what do my patients want, and what do my patients want me to tell them? And so I hope that this has given just like a little bit of food for thought around that. I think for those of you who are traveling to communities that you are not from, getting to know the history of the place you're going can really help you contextualize some of the things your patients are facing. And then some other resources, structuralcompetency.org is a website done by a working group that really focus on structural analysis, and they have like lots of materials and things to go through in some cases. And then the New England Journal of Medicine actually has started doing a case series in social medicine, and like sort of in the way that we do clinical case series, but really focusing on social solutions to the social problems and social determinants that our patients face. So I would encourage you all to look at that in your free time. And then maybe I'll just stop sharing briefly and see if anyone has like thoughts or questions. And feel free to this is hard to wrap yourself around, and so I'm hoping that this like sort of pushes people a little bit, but may feel a little bit kind of like uncomfortable and out of scope, and that's fine.
And I'm trying to put those links in the chat so that people.
Oh, yes, thank you. I can also send stuff out.
I'm curious to see if people on here who have pretty varied experiences, including a couple of people who have also worked in Haiti. Just curious how this kind of resonates with you if you had an opportunity to do something like this, structural analysis in real life, and if not, if you see a practical role kind of moving forward in your work incorporating this.
Hi, that may have been to me because I did put in the chat that I was working in Haiti. So I think I like the more formalized way of looking at things structurally. So we've been working in a very rural area in Haiti in the Plateau region, and what we found is that we started out building a clinic, but then discovered, of course, along the way, just like you did, that there were all these other issues that were so important, such as food insecurity and education and water source treatment and latrines. And so it's really become, over the last 10 years, a much broader definition of health interventions. And we've moved sort of from specific clinic to a much broader palette of support for the community. But it's very tough. I always kind of struggle with this. We were going in there and doing clinics every 4 months, and we were trying to do continuity, et cetera. There were some patients I know benefited from our immediate interventions. And yet, if you keep doing that, you don't build the long-term structures that you're talking about. And I always find that balance between saving the immediate person in front of you and building up the whole healthcare system is a very tough thing.
Yeah, totally. And I want to acknowledge that without clinicians to treat people, like if we all were like, oh, okay, I just have to go work and change policy, that like lots of people would die along the way, right? Because there are people who've been affected by like these centuries of policies that are sick now. And so this isn't a call for everyone to kind of switch. I mean, I still practice direct clinical care. Like this isn't a call for everyone to switch what they're doing. I think it's just like, yeah, can you hold that balance of like having multiple lenses at the same time and finding your allies, right? Because there are some people who have expertise or like a desire, there are lots of people who like want to do big picture stuff and don't want to do the direct care stuff, or like, hate dealing with parents or whatever it is, right? And so I think, and that you don't have to stay the same, I think, for those of you who know Sohail, like he went from a very like 100% direct care job that over the course of like 7 or 8 years to like all public health. And that's just where his career has gone and like will probably change in the future. And I think all of us hopefully will have the flexibility to like reach for like what do both like what does the world need now, like what does my community need now, but also like what do I need now for my own personal growth or satisfaction in my career. And I think the other anecdote that I'll put in here now is the one of the things that Partners in Health did that I think was different than many other international like NGOs working internationally is as HIV funding became really big in the early 2000s, I think, Barbara, just as you brought up, having realized that a lot of the health of their patients had to do with like access to food and access to like school fees and stuff, is they started using money that was grants and stuff that were for HIV and TB treatment to like actually buy people food, right? So if you were diagnosed with TB in their clinic, in addition to the TB meds, you got like X amount of money, or like X amount of like a bag of rice and like a bag of beans and stuff per week, knowing that like nutrition is actually really important towards like actually getting healthier or recovering from whatever illness. And so I think that was there's a term called vertical funding, which is this idea of funding for like one specific disease, so like HIV or TB. And then there's like horizontal care, which is like taking care of the whole patient. And so NGOs using like on the diagonal, or like calling that diagonal funding, so that they're trying to use vertical funding for horizontal care. I may have messed up those terms, but you get the idea. And I understand it's noon, and so some people may have to stop off, but I think we have like 10 more minutes. And so just briefly wanted to talk for those, I think particularly like the peds residents, for you all, just wanted to briefly talk about HEAL. And So the HEAL initiative is a health equity action and leadership initiative, and it's a postgraduate fellowship that I work for. And it is to train and transform, our mission is to train and transform frontline health professionals through building a community dedicated to serving the underserved, and really anchor in the idea that people coming together from various disciplines in healthcare can transform systems over time.
My little brother has type 1 diabetes. I'm at risk for getting it too.
If you have a family history
Sorry about the phone ringing in the background. So HEAL, we're kind of grounded in these values, and people can see it on the website, which is healinitiative.org, so I won't read through them, but really grounded in the idea of humility, immersion, and solidarity with the people we're working with. We work actually in a broader set of places now, but in underserved areas in California, Navajo Nation, and other tribal areas in the Southwest, along with a number of countries across the world. I think this is a unique global health fellowship program in the sense that there are people, half the fellowship are people who are trained in US healthcare profession training programs that rotate between a domestic underserved site as well as an international underserved site. And the other half of our fellowship are site fellows. So they're people who are actually working at all of our partner sites and have been there for some time and are either from those communities or planning on staying there for the long term. And everybody participates in the fellowship together. So it's a bidirectional program. It's interdisciplinary, which I think, so we've had physicians, nurse practitioners, nurses, social workers, dentists, pharmacists, all participate in the program. And it's really a fellowship about global health equity. And so I'm happy if anyone's interested, I'm happy to talk more about it. But I would consider it as you finish your training programs. I think it's a great program.
Thanks, Robin. Any questions from the group? I also wanted to point out, in addition to the HEAL initiative website, which I put in there, and a couple other links, we also have a very short evaluation link. It's literally 2 or 3 questions, and we do really value your opinion and your input, and we do revise things annually based on what you tell us. And I think maybe as a kind of trying to tie this together with some of the other sessions we've had some on implementation science, and really talked about how the care cascade for tuberculosis, for example, there's 1 million people who kind of drop off at each level when you're trying to diagnose them and then get them to treatment and then keep them on treatment long term. And I feel like the implementation science and the structural analysis piece really should be done hand in hand, because when you're thinking about where people fall through the cracks and where the health system fails them, a lot of times those are going to be overlapping themes.
One thing that I was going to mention that I remember from Mountains Beyond Mountains back in the day from Partners in Health is that they built a pretty extensive network of community health workers. And I feel like that is a way to kind of bridge and fill a lot of those gaps, is to have kind of local folks that are getting hired and trained to kind of do that ongoing work. And I think they are also such a great resource to understand better where places like food insecurity are showing up and what those barriers are. So I just kind of wanted to throw that out there as well. Yeah.
Yeah, and I mean, you could have a whole separate, I don't know, set of sessions on community health worker programs. I think totally true. I mean, they still real connection to the community. And I think one of the things that Partners in Health has talked about very strongly with their community health worker program is that these these people are doing real work and they should get paid. I think there are a lot of, I mean, granted, underfunded governments that like look for volunteer community health worker programs and they just don't have the same impact because you're asking for a lot of people's time and effort, and that needs to be compensated. And so I think Partners in Health has generally been really strong advocates for changing that norm globally. The other thing, sorry that I don't know your guys' schedule, but Teresa, does Ari Johnson talk about any of the MUSO stuff for them?
Not in the PEDS pathway. I don't know if he
Oh, yeah.
does for the GME.
Yeah, so another thing to look up about community health worker programs that is actually like pretty pediatrics focused is both actually, I think now they've expanded a lot more into maternal health as well. There's an organization called MUSO in Mali, and there are a few publications by them about the impact of their community health worker program on mortality actually. And it's really amazing work and amazing data, and they are worth checking out and learning more about how they have used community assets to really like save lives. And I can try to find their papers and have them sent out to you guys after this.
You find one.
Okay. Yeah. Oh yeah. I think this is more recent. I think in like I don't know, it's probably like 10 years, like 2012, their first paper came out about sort of the childhood mortality change with their community health worker program in the communities they work in. But I can find some actual information for y'all.
That's great. Any final questions from others on the call? Thank you for your time, Robin. Honestly, this is, I think, one of the most impactful and interactive sessions we have. So thank you so much for giving it and finding the time to be here.
Yeah, well, thank you all for coming and participating. And yeah, feel free to reach out with any questions about this or HEAL or whatever. I'm around. So
thank you.
Thank
hope
you
you guys
so
get a little break now.